Welcome back for part 2 of our deep dive into surgical antibiotic prophylaxis. In this session, we move beyond simple agent selection into the realm of precision implementation. For the clinical lead or surgical consultant, SAP is no longer a checkbox activity, but a sophisticated exercise in clinical pharmacokinetics. We will explore the mathematical mandate of tissue saturation, the physiological triggers for redosing, and the mounting evidence that our traditional, long-course habits are actively harming our patients. Slide 2. The stewardship imperative and global error rates. We must first confront the data. Nearly one-third of all inpatient surgical prophylaxis is improperly extended beyond the 24-hour mark. This error rate is even higher in public institutions, reaching over 36%. Often, this is driven by what we call the surgeon's benevolence, a well-intentioned but misguided desire to protect the individual patient from every possible risk. However, we now know that these good intentions lead to harmful outcomes by decoupling our practice from evidence-based guidelines. Slide 3. Baseline risk stratification, the wound gradient. A precision approach begins with the surgical wound classification gradient. For Class 1, clean cases, routine systemic SAP is actually not indicated unless you are placing a prosthetic or have a high-risk patient. Conversely, Class 2, clean contaminated cases, with a baseline SSI rate of 3 to 11% are the sweet spot for standard SAP. Once we move to Class 3 and Class 4, we are no longer talking about prophylaxis. We are initiating therapeutic treatment for established or imminent infection. Slide 4. T-5 days, targeted decolonization. Our timeline starts 5 days before the first incision. For high-stakes cardiothoracic and orthopedic procedures, WHO recommends targeted decolonization for known S. aureus carriers. This involves twice-daily intranasal mupirocin 2% ointment and CHG bathing the night before surgery. This pre-op purge reduces the risk of autoinfection from the patient's own skin flora, providing a sterile buffer before the systemic agents are even introduced. Slide 5. The pharmacokinetic mandate. Serum versus tissue peaks. The most critical insight for any surgeon is that peak serum concentration in the IV line does not equal clinical protection. The goal is peak tissue concentration at the exact site of the wound at the moment of closure. Mathematically, starting antibiotics after anesthetic induction in the OR is often too late to achieve peak tissue saturation. We must time our administration to ensure that as the knife meets the skin, the antibiotic is already at its highest concentration within those specific tissues. Slide 6. Agent-specific infusion windows. Timing is not one-size-fits-all. It is dictated by the agent's half-life. For standard short-acting beta-lactams like cefazolin, the window is tight, 15 to 60 minutes prior to incision. However, for glycopeptides like vancomycin or fluoroquinolones, the window must be expanded to 60 to 120 minutes. These exception agents require longer infusion times to avoid reactions and to allow for their slower distribution into bone and fatty tissues. Slide 7. T=0, procedure-specific selection grid. At the moment of incision, your agent must be matched to the predicted site flora. In cardiac and neurosurgery, our target is skin flora, MSSA, MRSA, making cefazolin or cefuroxime the gold standards. In colorectal surgery, we must add anaerobic coverage with metronidazole or utilize ertapenem. For orthopedic implants, we target biofilm-forming staphylococci. Precision means choosing the narrowest effective spectrum to avoid unnecessary collateral damage to the patient's microbiome. Slide 8. Intraoperative Dynamics. The redosing triggers. The OR clock dictates our intraoperative triggers. There are 2 non-negotiable rules for redosing. First, the procedural duration. If the surgery exceeds 2 half-lives of the drug, about 3 to 4 hours for cefazolin, you must redose to maintain the tissue MIC. Second, excessive blood loss. A threshold of 1.5 liters in adults necessitates immediate redosing regardless of time, as fluid shifts and blood loss physically wash the antibiotic out of the vascular space. Slide 9. Postoperative cessation. Dismantling the myth. One of the hardest habits to break is the postoperative safety net. However, a landmark meta-analysis of 44 RCTs conclusively demonstrates that prolonged prophylaxis offers 0% additional benefit in reducing SSIs compared to a single properly timed preoperative dose. The CDC mandate is clear. For clean and contaminated procedures, systemic antimicrobials should stop once the incision is closed in the OR, even if a surgical drain remains in place. Slide 10. Hidden harms, the exponential rise of risks. Why does cessation matter so much? Because after 24 hours, the risks of SAP rise exponentially, while the benefits remain flat. Every hour of antibiotics post-closure buys zero SSI protection, but actively purchases antimicrobial resistance and C. difficile colitis. In fact, patients without guideline concordant cessation face a staggering 6.7 times higher odds of developing C. diff infection. We are trading a non-existent SSI reduction for a very real and life-threatening systemic risk. Slide 11. Auditing and improving institutional practice. To improve, we must audit. Using tools like the Surgical National Antimicrobial Prescribing Survey, SNAPS, we can identify our facility's specific gaps. Improving practice requires a multidisciplinary synergy. Surgeons must own the SSI risk. Anesthetists must manage the infusion timing, and pharmacists must enforce the cessation wall. Timely feedback of this data to the surgical team is the most effective way to drive institutional change. Slide 12. Conclusion. The optimal SAP architecture. In summary, the optimal SAP architecture is a timeline of precision. Decolonize high-risk carriers by day -5. Hit the target infusion zone 60 minutes before incision. Redose at the 3-hour mark or 1.5 liters blood loss, and hit the cessation wall at the moment of wound closure. Success in surgical prophylaxis is not about how much we give, but about the surgical precision of when we give it.